Good evening, everyone, and welcome to today's wonderful session. Pramod Gurjar, Dhananjay Srivastav, and many more who are all online. To study alone is a very boring job. We should all meet every day, discuss about an hour, and then from there we should get inspiration to study together. There are a lot of videos, mock tests, flashcards, MCQs, question bank, everything is available on the Incus.online and also on the Incus app, which should give you sufficient amount of material for you to do the revision. But video is video, app is app, web is web, but what you require is a classmate, roommate, table mate, bench mate to study along with you every day and discuss the questions. So that is the whole purpose of the daily live classes. I hope you're all enjoying it. Thank you very much, Dhananjay Srivastav, Pramod Gurjar, and many more who are all online for joining this wonderful evening. There are many more teachers are coming who are currently doing for their post-graduation, who are the recent NEET PG toppers. They're all going to give you the essential thrust which is required to become a topper, is what I am promising all of you. So, doctor, let's make the great beginning. Once more, coming back to the general medicine, can online students can punch whether the voice is loud and clear for all of you, doctor? Yes. In diastolic heart failure, so basically there are two types of heart failures. One is heart as a muscle is destroyed because of the myocardial infarction, etc., etc. And the ejection fraction came down. That is called systolic heart failure. Whereas there are certain situations, for example, hypertensive individuals whose cardiac muscle is hypertrophied. In such people, the heart is not able to expand, unable to fill. So there the ejection fraction is normal, but still heart is not ready to fill and distend. The compliance is there, no, that is gone. Whenever the muscle in hypertensive individuals, cardiac muscle became hypertrophy. So with a normal ejection fraction, if the cardiac output decreases, that is called diastolic heart failure. Whereas whenever the ejection fraction decreases, then you call systolic heart failure. So the left ventricular ejection fraction is normal, then you call diastolic heart failure, which is very common in those who are having hypertension. And on ECG, what are the left-sided leads, doctor? V5, V6, V4, they're all left-sided leads. In the left-sided leads, you find tall QRS complexes, which are the sign of the hypertensive heart disease, is what I want to underscore to all of you. I think I forgot to, now you're able to see. Yeah, I'm sorry. Good. Now, doctor. Yes. Now, you need to know a bit about HOCM, one of the hottest topic for the entrance exam. So this is called four-chamber view of the heart. Four-chamber view of the heart. So in the four-chamber view, you are able to see interventricular septum, which is hypertrophied. And because of that hypertrophied interventricular septum, the left ventricular outflow, where will left ventricular outflows into aorta? So the left ventricular outflow into aorta got diminished because of the hypertrophied interventricular septum is what you need to basically remember. So there will be an asymmetrical septal wall thickening where, how do you know whether the septal wall is thickened or not? Basically, you will take septum to ventricular wall thickness. Septum thickness divided by ventricular wall thickness. If you look at this parameter, septum by ventricular wall thickness, then if it is more than 1.3, you call hypertrophic obstructive cardiomyopathy is what you need to remember. So a football player running to hit the goal suddenly collapsed and died with a syncopal attack. That is the classical description of hypertrophic obstructive cardiomyopathy. If you do the ECG, what do you see? You find tall, positive, hyperacute. Let me quickly come to the next important high-yield area. The next important high-yield area is myocardial infarction. I think we are getting a little interruption of the internet flow. Yeah. So just bear with me. Today internet is really tough. Doing tough. 1 minute. Yeah, I think the internet is getting better. Good to see Shreyas, Kothadia, and many more who are all online. Yes. Hope the internet is better now. Yeah. So the earliest, now, one of the favorite topics of the examiner is myocardial infarction. Everything, anything about MI, you should know for the tomorrow's NEET PG exam, doctor. What is the earliest change on ECG whenever there is a myocardial infarction? Tall, positive, hyperacute T waves are a important telltale sign of the ischemic vascular territory is what you should remember. So this is how you get giant T waves. This is the earliest ECG change in MI. One of the favorite MCQs in the tomorrow's NEET PG exam. Following that, there will be ST segment elevation. Then there will be a Q wave development, and the R wave become diminished. Then there is a return of ST segment to normal, and T wave becomes inverted. Then there is a loss of R wave, and typically in place of the R wave, you get a Q wave, no R wave. So Q is the negative wave before positive R wave. S is the negative wave after the R wave. If there is no R wave, if you only get this kind of a wave where Q and S merged, then that is basically called as QS pattern. So then there is a return of the T wave to normal. Then there will be persistent ST elevation if there is any left ventricular aneurysm. So this is how you need to remember the sequence of changes that you see whenever there is a myocardial infarction is what I want to underscore to all of you. So once more, summarize along with me. Giant positive T waves, first thing. Then ST segment elevation. Then Q wave development and R wave diminishes. Then ST segment return to normal and T wave inverts. And then there is a loss of R wave in QS pattern. And then there is a return of the T wave to normal. This is how the progression of the myocardial infarction changes. One of the favorite MCQs. So that is the reason tomorrow's examiner, whenever he asks you what is the earliest change on ECG whenever there is myocardial infarction, what will you tell? Hyperacute T waves, which are tall and positive, followed by elevation of ST segment, which is indicative of myocardial injury, and over a period of few days, T wave inversion. Finally, diminished R wave or Q waves appear. That is what you need to remember. So always, you should know that myocardial infarction is being divided into, yesterday we discussed now, STEMI and NSTEMI. That is how it is being divided. STEMI and NSTEMI. ST elevation MI and non-ST elevation MI. So, if you look at the myocardium has certain thickness, and there is an area which is called subendothelial part of the myocardium. So, whenever the subendocardium gets injured, ischemic, then you get ST segment depression instead of elevation. And once there is a transmural ischemia, then you get ST segment elevation. So only ischemia, you get ST segment depression. That is decreased blood flow, where only subendocardium is early to get affected. Later on, when the entire myocardium gets infarcted, then you get the ST segment elevation, is what I want to underscore to all of you. Now comes the hottest MCQ in the tomorrow's NEET PG exam, doctor. You have to be very, very, very sure about it. How do you define STEMI? How do you define ST elevation MI? How much elevation is considered to be significant elevation? Typically more than 0.1 millivolts in 2 or more contiguous leads. More than 0.1 millivolts. This is what you need to remember significantly as the significant ST elevation. Similarly, any new left bundle branch block is also considered to be equivalent to ST elevation to define ST elevation MI. So what are the various territories? What are the leads where you find the changes, doctor? Lead 2, lead 3, lead AVF, it corresponds to the inferior surface of the heart. And inferior surface of the heart is supplied by right coronary artery, is what you need to emphatically remember. Similarly, lead V2 to V4 on the front part corresponds to anterior surface, which is supplied by the left anterior descending artery. Left anterior descending artery. It is also called widow's artery because lot of heart attacks occur predominantly because of the occlusion of the left anterior descending artery, is what you need to remember. Then the lead 1, AVL, V5, V6, they're all on the lateral surface of the heart and they are supplied by the left circumflex coronary artery. This is what you need to ultimately remember. So, doctor, yeah. Now, there are certain proteins which are referred to as cardiac biomarkers. Now, one of the favorite MCQ I'm going to give to all of you. NEET PG exam में sure shot आने वाला question है. You have to be 100% sure. CPK levels, when will it rise, doctor? 4 to 8 hours and returns normal by 48 to 72 hours. So out of that also CKMB, CKMB isozyme is very, very important. Then cardiac specific troponin I and troponin T, they are very specific to the heart muscle. So one of the favorite questions asked by the examiner is cardiac specific troponin I and T. When will they rise? For how long they rise? When will they fall? You have to be sure. So they rise 3 to 5 hours after infarct. Troponin I levels remain elevated for 7 to 10 days. Troponin T levels for 10 to 14 days. So if you do troponin levels 6 to 8 hours apart, if they are not rising, 6 to 8 hours apart, if they are not rising, that excludes myocardial infarction. That is the reason it is a very sensitive, fairly specific indicator. Troponin levels for the myocardial injury is what you need to remember. So how do you diagnose myocardial infarction? Some of you are going to be top cardiologists within a short period of time, right? So that's the reason you have to be 100% sure doctor. Top cardiologist, who is going to be top cardiologist among you here? 1 minute. I'll just change my internet network so that you can get a better transmission. Just bear with me. 2 minutes, there will be interruption. 2 minutes interruption. I'm changing the internet connection. Yeah, there's a very good question from Janardhana Swami. This video and this PowerPoint, Doctor, shall be uploaded tomorrow morning into Incus app. This video and this PowerPoint, Dr. Janardhan, we will be uploading yeah. So all right. Sorry for an interruption. Uh, can the online students can punch whether the voice is loud and clear for all of you? Is the voice and video, are they clear for all of you? A little trouble with internet today. Yeah. So hope it's all good, fair and going well. All right. So doctor, now how do you diagnose acute myocardial infarction? At least two of the following three features. So what are the three features, doctor? A typical chest pain more than 30 minutes. Criteria number one. Typical ECG changes, that is hyperacute T waves followed by diminution of the R wave followed by ST segment elevation and all these things. Typical ECG findings. And elevated cardiac biomarker levels. So most of the times, just with the clinical history and ECG, even when the markers are pending, we will go by the clinical history and ECG and jump into an action to treat the patients. There are two things which are the close mimickers of myocardial infarction, and there you should not do thrombolysis. If you do, then problem is patient will end up in a severe situation. Only that two differential diagnoses you have to be 100% sure of it. Number one, aortic dissection. It often presents with unequal pulses, unequal blood pressure in the arms, and because of aortic dissection, there is an aortic insufficiency murmur. And on X-ray, very classical, widened mediastinum. So these are the important signs that you need to remember look for in aortic dissection. Otherwise, a close mimicker of myocardial infarction is what you need to remember. Similarly, acute pericarditis, it also presents with a chest pain, pericardial friction rub. But how do you differentiate that? In the case of the MI, only contiguous leads like 2, 3 AVF. If it is inferior MI, only in contiguous leads you find ST elevation. But in case of the acute pericarditis, though it presents with the chest pain, there is a diffuse ST segment elevation, which is rather than being limited only to one vascular territory, there is a diffuse ST segment elevation that is characteristic of acute pericarditis, and that differentiates it from the myocardial infarction. That is what you need to remember. So now comes an important decision. Doctor साहब streptokinase दे रहे या नहीं दे रहे. So how will you decide about the thrombolytic therapy indications, blah blah blah, everything? Thrombolytic therapy is indicated if these conditions are met. The clinical complaint should be consistent with an ischemic type of chest pain, because even reflex esophagitis also can look similar. ST segment elevation should be more than 1 mm. ST segment elevation ke bina thrombolysis unlikely. At least 2 anatomically contiguous leads, and no contraindications to thrombolytic therapy. Patient should be younger than 75 years, because above 75 years, any thrombolytic therapy is associated with hemorrhagic risk. Risk of hemorrhage is what you need to remember. So, doctor, you should know, how do you clinically manage myocardial infarction? Often, patient has got a significant hypertension in a case of MI. How do you manage? You relieve pain. Pain is a precipitating factor. IV nitroglycerin, beta blockers, ACE inhibitors. That is to treat hypertension during an episode of MI. There can be hypovolemia. like inferior wall MI, right ventricular infarction, there you have to give generous, rapid IV normal saline. But be careful. If there is only right heart failure, that's fine. If the right ventricular infarction or inferior wall MI is there. But if the patient is having a left ventricular failure, and by mistake, if you happen to give generous doses of fluids, then he will end up in congestive heart failure. Most important thing, in left ventricular infarction, when the patient is in left ventricular failure, you have to give diuretics. But right ventricular infarction or the inferior wall MI, they are the situations where you have to give large, rapid IV volume of normal saline is what you need to basically remember. Then if the patient is in shock, you have to give ventilation, oxygenation, primary PTCA, hemodynamic monitoring, intra-aortic balloon pumping, and dopamine, dobutamine like vasopressors that is required. Similarly, certain mechanical problems can occur. Myocardial infarction can be associated with papillary muscle rupture, severe MR, ventricular septal rupture. You need to handle them vigorously. Now, what are the causes? Why people with MI die? Because of ventricular tachycardia and fibrillation. So, defibrillate immediately. Lidocaine, procainamide, amiodarone, they're all the things that are given. There is no role for prophylactic lidocaine. And you maintain potassium more than 4, magnesium more than 2 is considered to be 2 milliequivalents per liter to handle the ventricular arrhythmias is what you need to remember. If there is a supraventricular tachycardia associated with MI, how do you want to manage? You need to do DC, cardioversion. If the symptoms are severe and if there is hemodynamic instability, then you need to give adenosine, metoprolol, procainamide to manage the SVT. Similarly, if the patient is having bradycardia, how do you want to manage bradycardia? You need to give atropine 0.5 to 1 milligram, and you should be ready with bradycardia patient anytime can go into cardiac arrest. So, pacemaker. If there is any risk for complete heart block or any new left bundle branch block is there, any new bifascicular block is there, you should be ready with standby pacemaker. So this is how you manage the complications of the myocardial infarction, which is the favorite question by the NEET PG examiner, is what you need to remember. So that is the reason whenever the patient comes to you, you should look what are the complications, any arrhythmias are there. So what will you do in a patient of MI? First, you will do initial assessment, history, physical examination. In ECG, you look ST elevation more than 1 mm, ST depression in anterior leads, cardiac enzymes. If they are positive, give IV access, cardiac monitoring, morphine, oxygen, nitroglycerin, aspirin. फटाफट 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 मोना अंदर जाना है. मोना क्या होता है? मोना मोना मोना. M for morphine IV, O for oxygen, N for nitroglycerin, A for aspirin. Aspirin should be given. And you need to consider for reperfusion therapy, thrombolysis or angioplasty. Angioplasty, when will you do? If the catheter lab is very close, nowadays cath labs, even in district levels, cath labs are available everywhere. So less than 1 hour to reperfusion. Similarly, any contraindication to the thrombolytic therapy is there, that is also an indication for angioplasty. Any cardiogenic shock, refractory ventricular arrhythmias or a large infarct size, in all those scenarios, angioplasty is preferable. Similarly, thrombolysis, there should be no contraindication. MI might have happened within 2 to 6 hours. Even if MI started within 12 hours, if there is a persistent chest pain or if there is any ST elevation, that is an indication for thrombolysis. But you should always carefully look for all the contraindications of the thrombolysis carefully. Any cardiogenic shock is there, you consider angioplasty. So this is how you approach. MONA is something you should not forget. Morphine IV, oxygen, nitroglycerin, aspirin 325 mg should not be forgotten. So if a patient with acute STEMI presents within 2 to 3 hours of the symptom onset, then reperfusion therapy is very much a right candidate. And ideally within the first 90 minutes is much better, right? So that is all the story of myocardial infarction and associated issues that you need to basically remember, doctor. Now, let us have a quick discussion on the next favorite topic for the examiner, AF, atrial fibrillation. You are going to learn at least 10 points about atrial fibrillation. First point, the most common arrhythmia that brings your patient to seek treatment. Most common arrhythmia, atrial fibrillation. What will the heart rate during atrial fibrillation? 300 to 400 beats per minute. Irregular ventricular response. On ECG, normally what happens on ECG? There is a P wave, QRS, P wave, QRS, absent P waves, irregular ventricular contractions. Now always when we talk about atrial fibrillation, you should remember, with the increase in the age, the risk of atrial fibrillation Yes, once more, sorry for an interruption. Today, internet is in a very bad shape. Yeah, so yes, doctor. I hope now I am a little audible. So, atrial fibrillation we are talking about 10 points about atrial fibrillation for tomorrow's NEET PG. Atrial fibrillation patients can go into thromboembolism, is what you do, remember. So what are the two most common causes of the atrial fibrillation, doctor? Two most common causes. Hypertension and coronary atherosclerosis leading to ischemia precipitating the atrial fibrillation is what you need to remember. So one of the very common question asked is, what are the causes of atrial fibrillation? Any structural heart disease like hypertension, mitral valve disease, ischemia, pericarditis, pulmonary disease, hypothyroidism, any pheochromocytoma, alcoholic cardiomyopathy. That's the reason atrial fibrillation is called holiday heart syndrome, is what you need to remember. Similarly, sick sinus syndrome, tachybrady syndrome, there are the various causes of the atrial fibrillation. So how do you manage atrial fibrillation? One of the favorite questions of the examiner. First, you need to hemodynamically stabilize the patient, then control the rate, give anticoagulation, and then try to do the rhythm control. Rate control followed by rhythm control. So whenever a patient of atrial fibrillation comes to you hemodynamically unstable, if he is hypotensive, angina pectoris, pulmonary edema, then you need to do urgent DC cardioversion is indicated. But if the patient is hemodynamically stable, blood pressure is not compromised, then you need to do the ventricular rate control. How do you do ventricular rate control in AF, doctor? Intravenous beta blockers, calcium channel blockers, digoxin, they all will neutralize the AV node and prevent the atrial fibrillation going into the ventricle, is what you have to remember. Similarly, there are certain precipitating factors like thyrotoxicosis, any heart failure or adrenergic stimulants. They can be a precipitating factor, so you need to correct them. That is very important. Then, how long is this atrial fibrillation? You need to take the history. If the atrial fibrillation is exceeding 48 hours, the risk of intra-atrial thrombus formation will increase. So, most of the times, the rate control is good enough to maintain the symptoms and managing the symptoms of atrial fibrillation. And if you want to terminate AF, the only effective way is electrical cardioversion. So that is the reason, if at all patient is having an AF whose onset is 24 to 48 hours ago, then better anticoagulate them for 3 to 4 weeks before you initiate the anticoagulation, is what you need to basically remember. Then after you do the cardioversion, how long you should continue anticoagulation? It is still required for about 4 weeks, is what I want to underscore to all of you. Then to maintain the sinus rhythm, so you have used cardioversion, you brought the AF into a sinus rhythm, and you are continuing to anticoagulate for about 4 weeks, that is all fine. But how will you maintain that sinus rhythm? For that, we use propafenone, sotalol, amiodarone. These are the drugs which are being used in order to maintain the sinus rhythm, is what I want to underscore to all of you. So now comes a very important question. What decides the prognosis of the atrial fibrillation? There are two important predictive factors for the prognosis. One is, what is the duration of AF? Second is, look whether, so you are having the atria and ventricles, right? Any left atrial dilatation is there, you check for that. If the left atrium is dilated, suddenly there is a poor prognosis in a patient of AF. So what are the two important factors that decide the prognosis of AF, doctor? Left atrial dilatation, there are none. If the atrial diameter is more than 4.5 centimeters, then cardioversion will fail to restore the rhythm. Similarly, the duration of AF. The longer the patient's duration, there is a very famous adage, atrial fibrillation begets atrial fibrillation. Atrial fibrillation से atrial fibrillation पैदा होता है. इसलिए longer the patient is in atrial fibrillation, the more likely that he will remain in atrial fibrillation. That is what you need to remember. So those who are having a chronic AF, the main management goals are rate control using the drugs that will cause AV nodal block, like digitalis, beta blockers, and anticoagulation is what you need to remember. Now, there are certain tools which estimate the risk of development of stroke in a patient of atrial fibrillation. इसको बोलते हैं CHARD S2 स्कोर. भैया CHARD S2 स्कोर में क्या क्या होता है? C for CHF, H for hypertension, A age more than 75, D diabetes, SC stroke, and transient ischemic attack history. That is the important thing. CHARD2 score is what you need to remember. So any patient who is younger than 60, without any evidence of structural heart disease, hypertension, or other risk factors for stroke, if he happens to develop AF, then that is called the lone atrial fibrillation. Lone atrial fibrillation का definition क्या होता है? Younger patient age, younger than 60 years, without evidence of structural heart disease, without hypertension or other risk factors for stroke, where the risk of the stroke is very low, अगर उसके अंदर atrial fibrillation है तो lone atrial fibrillation बोलते हैं. And lone atrial fibrillation के लिए anticoagulation का जरूरत नहीं है, खाली aspirin दिए तो काम चलेगा. So only aspirin may be used is what you need to remember. So now I like to ask you a few quick questions, doctor, before we conclude today's wonderful evening. A 28-year-old woman, she has rheumatic heart disease. Come on, you punch your answers. Please punch your answers, doctor. Now it is the time you all become interactive. Punch your answers. Yes, I'm waiting to see your answers. A 28-year-old woman, she has rheumatic heart disease, specifically mitral stenosis. What is the murmur that is most likely present? Come on, punch your answers, doctor. Before we conclude, every day we will also have a few questions that we will try to discuss. Can anybody shoot me the answer? 28-year-old woman who has rheumatic heart disease with mitral stenosis, which murmur is there? Now it is time for you to make the answer. Come on. So you should remember a diastolic rumble at the apex of the heart, specifically mid-diastolic rumble. A 48-year-old woman is noted to have atrial fibrillation with a ventricular heart rate of 140. She is feeling giddy, dyspnea with a systolic BP of 75/48. What is the most appropriate next step we want to basically do? So as we already discussed, significant hypotension hai to it is often because of a rapid ventricular rate. That's the reason DC cardioversion is considered to be the treatment of choice. Now, for which patient of atrial fibrillation you want to discontinue the anticoagulation out of these four scenarios? Typically, a 45, less than 60-year-old, no hypertension, no hyperlipidemia, no risk factors for stroke. Then you call it as lone atrial fibrillation. So that is best suited for the to stop the anticoagulation. Now 59-year-old on warfarin after being found to have chronic atrial fibrillation. She has an INR of 5.8, no overt bleeding. What is the best management of this patient? So you should remember the target INR is 2 to 3. If her INR is 5.8, ideally you have to act. But she has no overt bleeding. That is the reason you can stop, hold the warfarin and can wait for a while is considered to be the answer. A 45-year-old woman is noted to have giddiness, pounding of the chest. Her BP is 110/70. Her heart rate is 180 beats per minute. And she has delta waves. What is the meaning of delta waves? WPW syndrome. So if a WPW syndrome patient is having atrial fibrillation, how do you want to manage? There you cannot give digoxin-like agents which act on AV node. You have to use those agents which will specifically act on the re-entry pathways. And that is the whole purpose of giving. Procainamide is the drug of choice to control the rate along the accessory pathways. Whenever a patient of WPW syndrome is having atrial fibrillation is what you need to remember. That is all the story for the today's evening, doctor. I hope you all enjoyed a wonderful class. So every day evening, 1 घंटा हम सब मिलेंगे, पढ़ेंगे, तैयार हो जाएंगे, इंस्पायर होंगे और फिर इंकस ऐप में जाके रिवीजन करेंगे. Once more tomorrow evening with all of you. Good night.